Hi, this is Piyush Bhargava and I have an interesting case to share with you. These images are from a 57-year-old male diagnosed with prostate cancer in April 2017 when the biopsy showed bilateral foci and a Gleason score of 8. They underwent radical prostatectomy and pelvic lymphadenectomy in August of the same year, and the final path was T3B and N0. T3B means that one of the seminal vesicles was involved, and N0 means that none of the resected pelvic lymph nodes showed any prostate cancer. They presented with rising PSA. So 2 months after their surgery, their PSA was 0.1, but 3 months later, it rose from 0.1 to 0.9. They had a pelvic multiparametric MRI, which was negative for local recurrence. On the left of this slide, we have a representative image showing the urinary bladder, the vesico-urethral anastomosis, the site of recurrence, and we don't see any abnormal T2 signal to suggest locally recurrent prostate cancer. They also had a whole body bone scan which showed this solitary focus of increased uptake in the lower thoracic spine close to the midline. They had a CT scan of the abdomen. The images are shown in the extreme right, which showed this sclerotic focus in T9 vertebral body seen on the transaxial image in bone windows and also in the sagittal image again in bone windows. Now compared to the prior CT which they had in August when their PSA was only 0.1, this focus was new. It's not seen here on the transaxial image or in the sagittal image. Now putting these together, rising PSA, a focus of suspicious activity on the bone scan corresponding to a sclerotic new focus on the CT scan in the vertebral body, these findings are consistent with osteoblastic bone metastases. Now, they presented with bone metastases after they were initially thought to be having local disease which was resected and the lymph nodes were negative. The explanation for them developing bone metastases now is that their cancer was probably spread outside of the prostate and outside of the pelvis before they underwent prostatectomy. And what is an indicator for that? Their pre-surgical PSA was high at 11.1. So a couple of teaching points of this case are the pre-surgical PSA is important, and two, conventional imaging in form of whole body bone scan and CT scan is also important for these patients. Let's quickly review the Acr Appropriateness Criteria. There are now several modalities to evaluate patients after prostatectomy when they present with biochemical recurrence, which is rising PSA or a level of 0.2 nanograms per ml on 2 occasions. We can do C11 choline PET CT, we can do multiparametric MRI of the pelvis with and without gadolinium. We can also do F18 flucyclovine PET CT. These are usually appropriate as indicated by the Acr Appropriateness Criteria, but CT of the abdomen and pelvis with IV contrast and a whole body bone scan deemed may be appropriate can also provide useful information, such as in this case. Thanks for watching.